Well, I'm well aware that everybody here would normally use slides because I've had to use sort of reading desk is not obviously what people use because you don't get many sermons. It's not going to be a sermon, I promise you. I'm absolutely delighted to be here, and it's actually because of Jeff and Lorraine that I'm here. We go back a very long way. I'm not going to say how long. The reason I'm interested in this topic is because I suppose I was first introduced to it when I was still a student, and I have no claim to expertise. I'm not a doctor, I'm not a nurse, I'm not a social worker, I'm a jobbing rabbi. But I've been very interested in how, as a society, we look after people who are dying, and indeed how we look after people who are grieving. And it seems to me that Britain can wave many flags about how brilliant it's been in inventing, if you like, the modern hospice movement as we know it, but equally is to be hugely criticised. And I declare an interest. I chaired the review of the Liverpool Care Pathway, but it's to be hugely criticised for rolling out and continuing with some guidance for how to care for people who are dying, without at any stage evaluating whether that methodology was effective. And to come out with 12 separate editions of that guidance and never to do an evaluation seems to me extraordinary. So I did warn Jeff that I was going to be a little bit rude about some members of the medical profession, certainly not the whole medical profession. I'm related to quite a lot of members of the medical profession and seem to have been adopted by others, but it does seem to me an absolutely extraordinary, it's almost like a conundrum. How can you be best in the world at something and also get it so wrong at the same time? How does that work? What's that about? So I want to track back a bit and talk a little bit about the history, and I'll talk for sort of 40 minutes or so and then throw it open to everybody here if that works for everybody, and please do chip in and tell me where I've got things entirely wrong, because that's very good as well. So, I mean, you can go back into the biblical period and earlier if you want to look at how we've cared for people who are dying. But actually, for our purpose, largely, one wants to look at the 18th century and onwards. So, from the 18th century, you see real pain relief being used for people who are dying, mostly laudanum, various kinds of opiates, and deathbed scenes become fashionable, and you can see, go and look at some 18th century and particularly 19th century drawings, illustrations in children's books in the 19th century, and the illustrations will be of people dying peacefully, a smile on their faces, and looking up to heaven. That's particularly true of small girls. If you look at children's books, it doesn't seem to be the same for small boys, which I've never quite understood. And then if you look at the 18th century, and indeed to some extent earlier, but particularly the 18th century, you have paintings of usually the father of a family dying in a bed with usually a red blanket over him, and the family in serried ranks either side. And the father is dying patiently, but the assumption is he's been given a good old slug of laudanum, because otherwise he probably wouldn't be so patient, and he certainly wouldn't be lying flat with his arms stretched out in the bed because he'd be in too much pain. From the 18th century, you get the beginnings of thinking about death not being terrifying, having before seen death very much as a punishment for bad behaviour. It's the beginning of a change from some Puritan thinking. I'm not going to go into the theology. I could bore for Britain on that, but I'm not going to, because that's not what's relevant. And people talked about the ars moriendi, the art of dying, which was a concept that was invented in the Middle Ages, but was really reinvented and written about in the 18th century. And then we got the 19th century and huge funerals and horse-drawn carriages and horses with purple plumes and all of that. I don't know whether anybody else gets really into all of that stuff, but you can go to wonderful exhibitions of funeral architecture and what everybody did, and purple bands and black bands and so on. And then we had the First World War. And the First World War made people completely unable to talk about death in this country. And I suspect a lot of what I'm talking about actually derives from that. And we're actually, we're in the, as it were, centenary of the First World War. It's a good time to look back at that. So if you look at Britain in the First World War, virtually every family lost a young man. And if they didn't lose a young man in the war, and most families did, but if they didn't, they certainly lost their young people in the flu pandemic afterwards. And that killed the young more than the old, and it was a huge killer. And there's not, there was basically hardly a family in the land that wasn't affected. And that's when you see people unable to talk and actually use the word death or dying. And they start using all sorts of synonyms. And they start talking about hopping the twig. I don't know how many other people were brought up on Eleanor Fargen, hop the twig and a good job too. Yes, absolutely, people recognise that. But okay, that's when it comes in, is during the period of the First World War. Popped his clogs, fell asleep, moved into the next room, turned their toes up. I mean, you can go on and on and on. There are endless euphemisms and synonyms used for dying. But from about 1917, you find virtually no educated person in normal circumstances. It's probably different in medical education, but in normal social circumstances, people did not use the words death or dying. And people just pretended it wasn't happening. And to have the perfect storm, you've also got medical education moving more and more, and you will all know more about this than me, but moving more and more into a model of saying that what medical education is about curing. And actually the caring, the alleviating was far less important. And you can see that both in Britain, and particularly you can see it in the United States. And if you look at the Flexnerian model of medical education in the United States and tease out the principles behind it, it's very clear that, that the idea of caring for people and alleviating pain was way down the list compared with curing. And we became, if you like, a society that believed that we could cure everybody. Look at the discussions around the beginning of the National Health Service in this country, and the view that once we started a National Health Service, we'd have far fewer sick people because we'd have cured them all. And begin to stretch your eyes that the thinking did not encompass that there might be another generation of sick people who would come along. But that tells you a lot about the thinking. And I think it's really important just to have that in one's head as one thinks about how did we get thinking about death and dying so right and so wrong at the same time. There also seems to me to be an extraordinary thing that as societies, historically, we seem able to either be incredibly good at funerals and helping people who are bereaved and comforting the bereaved, or really good at looking after people who are dying. But most societies don't seem to be able to do both at the same time. And we are a classic example of that. We have historically been better, particularly when people were more religious than they are now, but we've historically been better at looking after people who are grieving. It's now gone the other way because our hospice movement has become so successful and palliative care is a major specialty, and now we're rubbish at looking after people who are grieving, but rather better at looking after people who are dying. I mean, I don't understand why, but that appears to be the way it goes. I think it's also worth adding into this thumbnail portrait of our attitudes to death and dying that the 19th century sentimentalised death in the most extraordinary way. How many people here love Jane Eyre? Yes, okay. Think about Jane Eyre and the sentimentalisation of the death of Helen Burns, who was actually her sister, Charlotte Bronte's sister. And think about how it was possible to write about somebody who was dying of TB, probably quite painfully, with pretty little in the way of any kind of alleviation of the symptoms, but that was standard 19th century fare. So we have the end of the 19th century, we become more sentimental, we get the World War I, and we stop talking about death and dying, and then everybody says, this isn't right.
That's very much a thumbnail sketch. And then along comes Cicely Saunders. And I don't know whether Cicely Saunders ever spoke to this great society, but I imagine that at some point she probably did. But Cicely Saunders was extraordinary. She wasn't the first person to invent the hospice movement. I think that probably or in this country, that title probably goes, it's very difficult to know whether it's true, but it probably goes to Mary Aikenhead of the Sisters of Charity in Dublin originally, and they came to Britain and founded St. Joseph's Hospice in Hackney. But she was certainly the person who founded the modern hospice movement as we know it, and founded, if you like, the specialty of palliative care. And she was remarkable. I knew her quite well. And she started off as a nurse. She then became what was known then as a medical social worker. She was watching people die in hospitals before the start of the NHS and then after the start of the NHS, and she was completely horrified by how people who were dying were treated. And when we talk about how brilliant Britain is, it's really the work of Cicely Saunders and everything that followed that has made Britain so incredibly good at end-of-life care. So what did she do? What was so extraordinary? Well, she was a nurse and wasn't allowed to prescribe. So she became very friendly with a woman called Albertine Winner. I don't know how many people here have heard of Albertine Winner, who was the first chairman of St. Christopher's Hospice and who was a doctor. And Albertine and Cicely, between them, worked out that it wasn't that you needed to prescribe far more morphine than was being used, but you had to titrate the dose, and you had to listen to what the patient was saying, and you had to give the dose of morphine according to what the patient said in terms of how much pain they were feeling. Actually, some of the evidence suggests that they used rather less morphine, but it's very difficult to tell. And it was all quite basic. I compared with now, it was all quite basic. She had looked after a patient called David Tasma. I don't know whether people know this bit of history. David Tasma was a Polish-Jewish refugee who she cared for as he was dying, trying to alleviate his pain. And he left her £500, when £500 was £500. And he said, it is for a window in your, well, he said in your room, but meaning presumably her hospital. And that's what they started St. Christopher's Hospice with. St. Christopher's opened in 1967, so it is actually in its 50th year now. And it transformed the care of dying people in that part of London, in southeast London. What was she trying to do? Well, she was clearly trying to deal with pain. And I think the first thing on her list was pain. But other people, GPs, anaesthetists, surgeons, general physicians had been trying to deal with pain before this. Oncologists had been dealing with pain for goodness knows how long. There's nothing unusual about dealing with pain. There were two things that were different about her. One was that she believed quite strongly that how you dealt with pain had to be led by the patient. And the other was that she didn't think that pain was only physical. And when you actually read some of her early writings, it's perfectly clear that she thought that when you cared for somebody in hospice terms, you were caring for them spiritually, you were caring for them psychologically, you were caring for them socially, and you were caring for them physically in terms of pain. And she developed this enormously, and she spawned, if you like, the discipline of palliative care. I think it's fair to say that she was very driven by her own Christian faith. And I do wonder whether, if she hadn't been such a profoundly believing Christian, whether we would have had the modern hospice movement in this country as we know it. I don't think we can answer that question. But I think one of the things we can say is that some of the early adopters in the 60s and 70s were also people who were profound Christian believers. Albertine Winner was the exception, she was Jewish. But it was very much Christian and very much based on an idea about spiritual care alongside physical care. So it wasn't only about physical pain, although almost all of the patients that they took were cancer patients. And you have to track back to the 1960s when people talked about the big C, and when people wouldn't talk about cancer, and having cancer was basically a death sentence, and people didn't think of cancer as a chronic condition as we do now. And indeed, there are still hospices around the country that will only take people who have cancer, motor neuron disease and AIDS, even though the numbers of people dying of cancer have gone right down. So, what did she do? She started by looking at pain of all kinds. She then developed palliative care as a discipline. She thought of new ways of caring. She challenged the values of the still quite young NHS. She said that compassion was as important as, if you like, the technical know-how of dealing with pain. I don't agree, I have to say. I think you need to deal with the pain before you can do anything else. But that was very much her belief. And it was brilliant. It did transform people's lives. But even more interesting than that, and surprising in Britain, it became hugely popular amongst the wider population. So it wasn't something that stayed within, if you like, the medical and nursing, the healthcare world. It was something that gripped the imagination of loads of people in the general public. And even in the very early days, the late 60s and early 70s of the first hospices, huge numbers of volunteers turned up to help. And it became one of the most popular human charities. Obviously didn't match animals. And you can look at Oxford, where Robert Twycross was one of the absolute pioneers, again very much moved by his own Christian faith. Donald Richards, a GP, father of Mike Richards, whom some of you will know, who's the chief inspector of hospitals. But Donald Richards actually was the first person to take me around a hospice. He took me around the Sobel Hospice in Oxford. In London, there was a nurse, Harriet Copperman, who was very much involved right from the sort of start of St. Christopher's. She trained in palliative care at St. Christopher's and then developed her own palliative care service, and so on and so on. And most of you know how it developed. People became specialist palliative care physicians, specialist palliative care nurses, specialist palliative care counsellors, specialist palliative care psychologists. And the skills of dealing with the pain itself and also dealing with people's emotional and psychological and spiritual pain were very carefully honed and very well trained for. I have an objection to some of this, which is that at its worst, they said that they could deal with all physical pain. I think that we know that in the late 60s and 1970s, not so true now, they were very poor at dealing with bony pain. And I think that there was a bit of a con going on. Whilst they were providing a wonderful service, there was a bit of a con going on because they actually hadn't solved how to deal with some of the intractable pain that some people with bony cancers were experiencing then. Much better now. Okay, I'm now going to jump 40 years. The palliative care movement became so popular and so ever-present that eventually the view was that the skills and the techniques should be rolled out in shorthand form to the wider NHS, because it was only ever going to be a very small proportion of patients who could be treated in hospice or indeed treated by palliative care teams in the community. And even now, it's about 4%, if that, who actually will die in a hospice, and maybe another 15%, if that, who will get specialist palliative care in the community. Depends where you live. Quite interesting that, you should actually, people choose where they live for the schools. My view, choose where you live, according to the palliative care team, be much more sensible. But anyway, so the big cancer charities get very involved. Marie Curie gets very involved. Macmillan gets very interested, Help the Hospices, and so on. And eventually, they developed the Liverpool Care Pathway because it was developed in Liverpool at the Marie Curie Institute in Liverpool. And the Liverpool Care Pathway takes the principles of palliative care developed originally at St Christopher's but honed and spread across hospices around the country and codifies them. It's a bit like the Ten Commandments. In fact, it's very like the Ten Commandments because what they actually managed to do is they produced, if you like, quite detailed guidance. But they also had a top sheet which had the very basic principles and a checklist on the top. And what happened was that in most cases, by no means all, but in most cases, there was no proper training in using the Liverpool Care Pathway. So that what happened was you had junior doctors on, often at A&E, at the weekend. Never ever get sick at the weekend, particularly not between about 10 at night and 4 in the morning between Saturday and Sunday. I think any doctor would give you that advice straight off. Okay, but that's when you had young doctors on who hadn't been trained and who would look at some older person who was brought in moribund, very often because they'd come in from a care home and they were dehydrated, and say, this person is dying, and put them on the Liverpool Care Pathway. And they'd put them on the Liverpool Care Pathway, and then they'd go through the checklist. And the checklist says things like, have you considered whether this patient needs hydration? Tick. I've considered it. Haven't done anything about it. Haven't actually given them anything to drink or given them a drip, but I have considered it. And one of the things that went so terribly wrong was that in generalizing from the very magnificent skills of palliative care at its best into a codification, at worst, what you got was people using a checklist rather than actually thinking about what they were going to do. And it was really dramatically terrible. I didn't expect to be shocked. I'm not that easily shockable. And I was asked to do the review of the Liverpool Care Pathway after the department had originally decided that it was going to do it internally. I don't know whether people remember this. It's now 6 years ago it started. But what happened was that both in the Daily Mail, of which governments of any political persuasion are absolutely terrified, and the Daily Telegraph, stories started appearing of people being put on the Liverpool Care Pathway. And the descriptions in the newspapers was this was the death pathway. There were also accusations, totally unjustified, but there were accusations that people were deliberately being put on this death pathway in order to free up beds in the NHS. So you can imagine how well that went down. And it started with a few odd stories, both in the Telegraph and the Mail. And then more stories started appearing. And the staff in the civil servants in the Department of Health made a huge mistake because they decided that this was just a few troublemakers and it wasn't serious. And they decided that eventually it got so many of these stories appeared from all over the country, they decided they'd have to do something. So they set up an internal inquiry. And then things got worse, so they decided they'd better make it external, at which point I got the call. I have to say I got the call on the 23rd of December. Could I get it done by March? No. And they wanted the inquiry or the review to be conducted externally. And I think the department made a huge mistake in even starting it internally. I think by the time you're getting stories, even if you hate the Telegraph and you hate the Mail, by the time you're getting stories that are coming from different places all around the country, this is not a few troublemakers. There's something going on. It may or may not be wholly true, but there's something going on that should set your alarm bells ringing. And they made a mistake because they acted too slowly. So I didn't have any choice in who was on my review panel. And we very deliberately didn't have a palliative care specialist. We had a palliative care specialist to be an advisor to the review panel, but we didn't have a palliative care specialist. And what was interesting is that you couldn't have put a sheet of paper between us. We were all very different people, but you couldn't have put a sheet of paper between us when we actually heard what we heard from families who'd experienced actually quite atrocious care around the country. And most of it was this kind of extraordinary thing of saying, I've decided this person is dying. I'm putting them on this pathway. No explanation was given. People didn't know what the Liverpool Care Pathway was. They didn't know why it was Liverpool. One of the patients apparently used to say, but I don't want to go to Liverpool. And another one said, but what's a pathway? They knew what care was. But there was a lot of real angst, real disquiet, and quite a lot of serious distress. There was one time we were standing on a station platform, not a million miles from here, but I won't tell you where we'd actually heard from families such distressing stories that we were all standing on a station platform in tears, and that included the former head of the Defence Staff, Charles Guthrie, who's quite a tough nut, really. It was quite shocking. And we also heard of people crying out for water or for a cup of tea and not being given it. And we simply couldn't understand it. There's no justification for that. The guidance doesn't say it. So it wasn't about the guidance. It wasn't about the Liverpool Care Pathway itself. It was about how it was being used or misused. And it was about lack of training and no insistence that people who were likely to have to encounter quite a lot of old people and frail people, how they needed to be trained to tell the difference between somebody who's dehydrated and somebody who's actually dying. And that was quite alarming. Now, the other side of this is that we saw some absolutely remarkably good care. And what was perfectly clear was you didn't have to be in an all-singing, all-dancing, very fancy and beautiful ward. You could be in one of the oldest wards still in active use in the country, where there was actually nowhere for a group of us to stand. It was so crushed and crowded, but the care would be totally superb. And you could be in a spanking new, wonderful ward, and the care could be absolutely atrocious. But what was clear was there was a complete disconnect where it was bad between the purpose of the Liverpool Care Pathway and what people were actually doing. Now, we ended up recommending that the Liverpool Care Pathway be scrapped. John Ellershaw was extremely upset. He was the person who designed it originally, and there were 12 iterations of it. We were critical of the fact that it had never been evaluated. I'm still very critical of that. I think if we believe in evidence-based medicine and evidence-based healthcare, I would expect it to have been evaluated. There was virtually no research in palliative care as a whole. We were really shocked by that. And the worst of the care was an absolute disgrace, when the best of the care was wonderful. Now, all of that has to be set against extraordinary evidence. Like, for instance, there was the Quality of Death Index, which was published by the Economist Intelligence Unit in 2015, which ranked palliative care across the world. And Britain came up well on top. So even when I say some of the care was a disgrace, clearly we did very well, and we produced some absolutely fantastic palliative care. And what we had done, and that's actually what the Economist Intelligence Unit picked up, was not only did we do it very well when we did it well, but it was hugely integrated into British society and British thinking, and people thought in hospice terms and palliative care terms. They thought that it was valuable to support your local hospice. They thought it was a good place to volunteer. People thought that the work that was done in hospices was totally magnificent. So, why do we do it both well and badly? Well, let me suggest a few things. First of all, I think there was that sense, as the first of the Liverpool Care Pathway was being rolled out, that it was clearly so much better than what had gone before that you didn't need to evaluate it. It was obvious. You know, it's that thing, it's common sense. You didn't need to think about it. That's always intellectually very dangerous, but I think that is what happened. Secondly, there's virtually no money available for palliative care research, and that's still true, and I think that's a scandal. So even if you wanted to do detailed research in the field of palliative care, yes, there's a bit of money available now, there is a small pot, but it's extremely difficult to get the funders to take it very seriously. And when you talk to some of the big private funders, the Wellcomes and so on of this world, it's still not at the top of their list. They like all the biomedical stuff. They're much less interested in what they see as soft medicine. I think it's kind of crazy because we're all going to die. But anyway. Then I think there was something else which came out really just after we'd done our work, which there was a piece of research, which I don't know whether people here know Irene Higginson, but Irene Higginson is Cicely Saunders Professor of Palliative Care, and she was involved with an Italian team evaluating whether using the Liverpool Care Pathway improved the outcomes for people who were dying. And they set it against what everybody else would get who wasn't getting the Liverpool Care Pathway in the Italian system. Italian system is obviously different from the UK system. But the evidence was very clear that it actually made no difference. Now, you'd have to ask the question why we had been, as a matter of national policy, rolling out the Liverpool Care Pathway without that kind of research having been done. But it was never done, and it was eventually done in Italy and not in the UK. So what's gone wrong? I think I would argue that three things have gone wrong. Firstly, I would say it lies in medical and healthcare professional in general training. I think it's extraordinary how little training young doctors and nurses in training get about looking after people who are dying. It's one of the very few things you know that everybody is going to do apart from being born. And it's absolutely dramatic. When we were reviewing the Liverpool Care Pathway, a group of final year medical students came to see us at their own volition. I mean, they asked to come and see us, to tell us about their experience. They were from different medical schools around the country, and they were very disturbed because they said that almost all of them had one afternoon on palliative care in their entire course, and that was voluntary. Now, if you went on to do GP training, that wouldn't be the case. But if you didn't go ahead and you didn't do GP training, then that might be all you got and you could miss it. And they thought that was disgusting. I mean, they were very shocked by that. And one of the recommendations we made, which has been very slow in the take-up, but it is gradually happening, is that there should be far more training around end of life for medical and nursing students. So that's the first thing. But of course, medical and nursing students are very much trained in the model of the people who train them. And the people who train them also didn't have any training in end-of-life care and working with people who are dying. And you can go back generation after generation, or generation before generation, perhaps I should say, and people won't have had any training in that field. So unless you yourself became particularly interested, it wouldn't be stuck in front of you as a must-do. You'd do a whole lot of other things that you would have to do. You'd have to do your pathology, you'd have to do some surgery, you would have to do some psychiatry, lots of things you'd have to do, but you wouldn't have to do palliative care. And your teachers didn't, and their teachers didn't, and their teachers before them didn't. So that's the first bit, and that's why it's not surprising that it hasn't been taken seriously. Secondly, although we talk about evidence-based medicine and evidence-based healthcare, we're still a long way from having evidence for everything that we do in the healthcare scenario. And palliative care, being one of the newer specialties, is more likely to suffer from lack of research funding than some of the older specialties, partly because we haven't been that quick to actually pick up the evidence. And one of the recommendations we made was that there does need to be research. And I'm still working with Sam Ahmadzai, whom some of you will know from Sheffield, who is pushing hard for research in this area, because it's absurd. And the third thing is a kind of attitudinal one. And it tries to answer the question of why we're so good about it and so terrible at the same time. And it's that curious thing, the 1066 and all that thing, of palliative care is a good thing. Therefore, because it's a good thing, we don't need to question it. We may not teach it, we may not study it, but it's clearly a good thing. Hospices are fashionable. The public loves them. So there's something about our mindset that says because we know hospices are wonderful and that work that's done in hospice and the way people are cared for in hospice is so wonderful, because everybody's so incredibly grateful, we don't have to test it out. So we do it well. The Economist Intelligence Unit is right. We do at best do it incredibly well. But at the same time, and that's really clear, we're doing some things in end-of-life care that we probably shouldn't be doing, and things that show no evidence of making a difference, different from what we would do if we weren't using the Liverpool Care Pathway or the Amber Care Bundle or any of the other pathways that have been developed. And I think that's really quite difficult. It's quite difficult for people to get their heads around that. But I think that's actually the nub of it. We think it's a good thing. In fact, we know, in our bones we know it's a good thing. Therefore, why would we test it? And so we don't test it. And so it was possible to go for 12 iterations of the Liverpool Care Pathway without ever evaluating it. And we don't test it, so we don't do the research, because in a sense you want the money for the treatment, so you don't want to waste the money on research, and you get yourself into an intellectual mess. We know it's good, so we won't tease it out. And yet, as we saw when we really looked at it closely, around the country, we had a huge variation between absolutely superb care and absolutely appalling care, all using the same guidance. And I think that's really interesting. I'm going to finish because I want to engage with all of you in a minute, but I want to say one other thing that I think is important. When we were looking at the Liverpool Care Pathway, one of the things that was very clear was that we were looking at, if you like, a microcosm of what was going wrong with the care of older people in the country. Because although not everybody who dies is old, more older people die than young. It's kind of obvious. Anyway, it was sort of at the time of the Mid-Staffs inquiry. And Mid-Staffs inquiry showed some very shocking treatment of older people. So I think there's another strand in all of this, which I don't know enough about to say anything other than saying I think there's something here, which is that I suspect one of the reasons as well why the research hasn't been done, the testing out hasn't been done, is that a lot of the people who are being cared for who are dying are old. And in our healthcare system, if you look at the way it was created, that's abundantly clear. We value the young over the old, and therefore would be more inclined to conduct research in areas that we think are going to be of benefit to younger people than older people. And I think there's quite clear evidence of that. I think you can also look at geriatrics and have a look at that. But it did seem to me that more money would have been made available for studies of palliative care if much younger people were dying. If you look at the amount of money that's made available specifically for children and teenagers who are dying, compared with everybody else, you'll see that is the way we think. We may not think we think that way, but you can actually test it out by looking at how money is allocated. And I think that often tells you a lot about all sorts of things. So where would I leave this? I'd leave this by saying I still think we're brilliant at caring for dying people, and I'd rather die in Britain than almost any other European country, and certainly far more than in the United States. I think at best you get incredibly good care. I think we have incredibly good palliative care teams in the community, and I think we have some very fine hospices in the country. But I do think that because we all think that, including me, we're reluctant to test it out. And I suspect that although it's good, it could be hugely much better. And one of the things that struck me when we were going around looking at care being given in various places was that in the places where you could tell that the institution itself was taking care of its dying patients very seriously, they were also doing, often quite small bits, but they were also doing some research. And so I think I'd end with saying that I think there needs to be an intellectual approach to this and a bit of rigour around here. We can care for people and cherish them and show compassion and give them spiritual care and psychological support and all that. But unless we can demonstrate that what we're doing is of benefit, I think that we're being intellectually lazy, and I think we're letting emotions and public, if you like, popularity of something defeat our belief that evidence matters. And I'll leave it there. Thank you very much.